So our next speaker is going to turn to how do we pay for all of this. The title of her talk is The Heart of Healthcare Reform, and sort of the subcontext is what the Affordable Care Act can and cannot do. And it's a pleasure to have Jandel AllenDavis here with us today, a physician who is the Vice President of Government, External Relations, and Research for Kaiser Permanente, Colorado. Jandel.
And there it is. Now it's on. Well, thank you so much. This is like such a thrill to be here. And I sat there at the end of this last presentation and thought two things. And what I'm actually going to talk about is a little bit of a variation, or perhaps a little few off of what you talked about. But I said, I loved the questions. And I loved this last talk. And I loved it not only for the science, but as I was hearing the questions, one of the things, and maybe it's because we're in Boulder as opposed to Denver, the sense of community. And that's what came through in the questions. And the work you're doing is fabulous because you're blending the science with this sense of the heart, engaging the heart. And until we do that, we're going to be in some crazy space for the next many, many years in healthcare. So first of all, Larry, thank you. Thank you for the opportunity to do this, to come and share maybe a little bit different message, but perhaps not. But I think certainly it is one that I think we need to think about as we think about healthcare, and we think about big data, and we think about science, and we think about behind the numbers, the data, the science, they're people. They're people who are out living their lives. Your kids and families are out living their lives, and certainly for the 25 years that I took care of patients, and can't believe there are adults running around who I delivered, but I'll deal with that. It's 2:30 in the morning, I suppose. What it tells me and what I know is that we are at both an exciting and a super confusing time in healthcare. As I look at it, and even thinking, having had the opportunity a few weeks ago, hi Tom, to participate in 10-10-10 and hang out with entrepreneurs and folks who are looking to invest in healthcare and trying to figure out how do we help navigate that in a way that does achieve what we're trying to achieve in healthcare. It's really clear to me that all sorts of opportunities abound, that solutions aren't going to be readily apparent, and in a crazy way, the level of cacophony that certainly I've experienced, and I think all of us who are sitting there in the nexus of healthcare have experienced in the last many years, the cacophony is actually deafening, so we're not exactly calming anything down. And then to top it all off, those of us who are sort of sitting in this nexus of healthcare are a little bit tired. In fact, I was this crazy person who practiced OBGYN for 25 years, made a decision when a door opened to walk through it and take this job on the health plan side of Kaiser Permanente after being on the Permanente, the physician side, in April of 2009, and then the Affordable Care Act passed in 2010. And I went, oh my God, what a time to change a career and get on yet another incredibly steep learning curve. And what I can tell you 6 years later is that it's been a wild ride, and it's been an exhausting ride. And at the same time, I just feel so privileged and blessed to have hopefully been a part of making something different. And despite all the exhaustion, the cacophony, I firmly believe we're on, and I said it in my notes there, the verge of something pretty darn transformational. But it's going to take some things. It's going to take courage. It's going to take ingenuity, a sense of a creative spirit, and frankly, something that was said, just sheer will to ride the wave of change that's in our midst. So first, I just want to tell you a story, and it's one that maybe you all have heard, and this will be I think it's only, maybe there's one other shameless plug I'll make. I may say Kaiser Permanente once, I guess now twice since I said it then. But I had the privilege in 2013 of participating in TEDx Mile High. And did a piece with actually actors on the stage that Kaiser Permanente employs called The River of Health. And so that was my TED Talk. And it started with this story. I'm standing by the shore of a swiftly flowing river, and I hear the cry of a drowning man. I jump into the cold waters. I fight against the strong current and force my way to the struggling man. I hold on hard, and I gradually pull him to the shore. I lay him out on the bank and revive him with artificial respiration. Just when he begins to breathe, I hear another cry for help. I jump back into the cold waters. I fight against the strong current and swim forcefully to the struggling woman. I grab hold and gradually pull her to shore. I lift her out onto the bank beside the man and work to revive her with artificial respiration. And just when she begins to breathe, I hear another cry for help. Again, I jump into the cold waters, fighting against the strong current. I force my way to the struggling man. I'm getting tired, and so with great effort, I eventually pull him to shore. I lay him out on the bank, and I try to revive him with artificial respiration. And just when he begins to breathe, I hear another cry for help. Near exhaustion, it occurs to me, I've been so busy jumping in, pulling them to shore, applying artificial respiration, that I have no time to see who is upstream pushing them in. And the interesting thing, this was actually a story I did a little bit of hunting for as I was preparing this TED Talk some years ago, that it's actually a metaphor that's written by a now deceased medical sociologist named Irving Zola. But when I'd heard it years ago in healthcare, it was that we're all so busy downstream pulling bodies out. We don't even have the time to go upstream and see who's throwing them in and tell them to stop it. So it really beautifully and yet tragically tells the story of how the American healthcare system is set up. And I would dare say, having spent 4 weeks abroad last year with an organization called the International Federation of Health Plans, it ain't happening much better anywhere else. We are all so focused downstream on healthcare, which we need to be. So please don't hear that as a message that I think we need to abandon that. But there is work to do there. So I'm going to see if I can get this thing. So what I decided that maybe that I wanted to do, and it's been a few weeks since you asked me, it's like, how was I going to pull together? How was I going to make that thing fall down? How was I going to pull together a myriad of thoughts that are sort of rambling through this head, thinking over the last, 30-some years that I've been involved in healthcare, but also have this amazing love of and sense of the need for community to pull thoughts together. So last night, believe it or not, I finally said, you got to write something. So I wrote just a bunch of brain droppings, as it were, and that's what I'm going to pull together, I hope, into something that works for you. And the first one is this notion, and it is where I started my TED Talk, which is that healthcare is broken. But more importantly, and this is the thing, fixing healthcare alone is not going to fix healthcare. When we think about what the ills are that are facing us, it's not affordable. The quality is varied at best. And the service and the care experience that any of us have is, again, varied at best. There's work to do. And we know that if we just focus on the healthcare system, we're not going to necessarily fix healthcare. Certainly we know the statistics. Pre the Affordable Care Act, there are about 50 million Americans that we knew of who are uninsured. The rate's down to about, and that was at a whopping about 18%. We're down to about 11.9%, and in Colorado, we're down to about 11.2%. But the healthcare expenditures are going up. They were coming down for a while there, and interestingly, those of us close to the work knew that what was really going on is that was a reflection not of anything we were doing under the covers. Well, that sounded obstetrical. Not anything we were doing in the actual healthcare system, but it was a reflection of the fact that we were in a recession, so people actually had less income. So in 2013, the expenditures in this country for healthcare was $2.9 trillion. We're up to about 18% of GDP and climbing. It's quite frightening to think that this thing, if we keep on this particular path, that it could eat up most of our budget. And then there was this news. As we look at the quality rankings, the United States healthcare system, in addition to being the most expensive in the world, if you look at the OECD reports and look at 11 comparably sized nations that were studied in this report, Australia, and from an economic perspective, Australia, Canada, Germany, France, Netherlands, and the list goes on. The United States ranks dead last in terms of quality, and as this particular graph shows, yeah, I did do that right. The interesting thing is, here's how. This is what we know makes us healthy, and I'll come back to later. But this is how we spend our money. Most of our money is actually spent on healthcare services. And this is the slide that shows for all of this spend, we are dead last when it comes to overall healthcare rankings. And those rankings are based on some pretty common things. It's like childhood and neonatal mortality rates. It is the average life expectancy of Americans in this country, in the Americans compared to the others. So we're last or near last on a host of issues of access, efficiency, and equity. And the interesting thing when we ask ourselves, why is that? There are a number of contributing factors. But at the heart of it, we're very, we're so sort of careless with our language. And we call what we have in this country a healthcare system, when in fact it isn't a system. And a lot of us call it the healthcare non-system. So how would we go on and really create a system? Well, as I thought about it, the next little brain dropping that came to mind was this notion of we love our toys. And we do love our toys. And we love a few other things too. And those things are getting in the way of the ability to live a healthy life. So I wear, pardon my rudeness here, I love my Fitbit. I'm 3 years into my Fitbit. You know, we love these little things. As it turns out, fitness devices, which there's been just a mad rush to the development of. And folks are making big bank on them. And I'm ready to go buy the next cool one, but I won't because I'm 3 years into mine. But a third of Americans stopped using these devices within 6 months of purchasing them. Right? And these were the fitness trackers that were supposed to help us keep going. Another one showed that 1 in 10 of us Americans own one of these, but only about half of us are even using them anymore. And then when you go and you look at the medical, this may get me thrown out. I don't think it will, but you think okay, I won't get there. Regina Hertzlinger, who's an amazing professor at Harvard Business School, who's written a phenomenal article on innovation in healthcare, that if you're interested, it is worth finding. It's a ginormous article, but it is fantastic. And what Regina figured out was that in the 30 years of public existence, the biotech industry has experienced a cumulative net loss of $40 billion, and the investment size has been $100 billion. So we love our shiny objects. We love our toys, and I sure loved mine in the operating room. Couldn't wait for the next cool laparoscopic, you name it, to come along. And we weren't necessarily applying those technologies in a precise way. So we love those. But then a few other things we love in healthcare that are not so granular or so able to be touched. We physicians and healthcare providers love our autonomy. In terms of us as consumers, we love insurance. We love coverage. That's what the Affordable Care Act was about. But we do not necessarily appreciate the impact on healthcare cost of moral hazard. That is that the cost of healthcare is so hidden from most of us, from all of us, including physicians, that people are outraged when they find out that they have a bill of, they would have to pay a copay of $250 or $500. I can certainly understand it, given certainly some folks and many folks in our country's economic state, but they have no idea the denominator, which can be thousands, tens of thousands, in some cases hundreds of thousands of dollars more than that. So insurance, health insurance actually shields us from the true cost of care. So, you know, the other thing that we love also is America's sick system. It's not a healthcare system, we say. It's a sick care system, and it's the best in the world. You get hit by a bus, do it in America. Don't do it in some other countries. This is the place you want to be. We are fabulous at rescue medicine, fabulous at it. Where we're not doing so well, which is what explains what I showed you earlier on that slide, we don't do this prevention. We're not getting, as the metaphor talks about, upstream from things. And on top of it, we are an unhealthy nation for all of our wealth. And we know that, and that's sort of what the implication. I love the guy walking his dog with the car. Or certainly the foods, which we get more and more creative in our ability to consume calorie-dense foods that are nutritionally bereft. And so then we come to this thing called the Affordable Care Act, and we've decided that this is going to be, there are some people who were cheering in the aisles, or some people, and we know this has been an interesting 5 years to have government in anywhere near your title. But the interesting thing about it, as we've thought about what's really going on there, is the Affordable Care Act is not the end of healthcare reform. It's the end of the beginning of healthcare reform. We'll be working on this darn system in our lives long after most of us in this room close our eyes. Now, it doesn't have to be that way if we can get about courage, will, checking some egos and some titles at the door, beginning to think through the lens of abundance. I think we could actually maybe accelerate some of the changes that are desperately needed in this country. So the Affordable Care Act has done that. It's created a real need for transformation in a number of systems. And the numbers that we know in terms of the 11.9% that we've managed to bring healthcare, the lack of coverage down to, the uninsured rate down to, hides some not so startling facts. And I think if we think about it, we know this. Number one, coverage doesn't equate to access to care. We did not magically create a healthcare workforce that was ready to absorb not only the numbers of people who we poured into the system, but the complexity of care and needs. And I'm not just talking about physical needs, I'm talking about human needs, social needs, and we'll come back to that. And coverage doesn't equate with affordability. Healthcare is not affordable, and in fact, one of the things that it's been interesting watch, and the market's going to be crazy over the next many years, is watching how health plans are pricing their products, whether it's on the exchange or off the exchange or in the individual market, the large or the small business, small group market. It is still not affordable, and there's a whole lot of interesting pricing dynamics that is going to give us all quite a bit of whiplash, whether we're right there in it as a health plan executive, that I am these days, or those of us when we're in the consumer game. So what we have essentially done is we're watching rates come down, and there's a fair amount of celebrating. Realize that we've done very little to actually transform the system. What we are doing is artificially tamping down rates. And it's going to create a lot of market turbulence over the next many years. And probably most notably, and this is what I want to spend the rest of the time hopefully talking about, is that coverage is not going to magically transform our health status. It's not going to transform our health, nor is it going to magically transform our healthcare system. Although it has been fun to watch what's happened in the last many years. And we, for those of us who live here in Colorado, are blessed to have a lot of folks and a lot of organizations and foundations and others that are interested in really trying to transform and see if we can build a system in this state. It actually started back during the Owens administration with the 208 Commission. So what do we really need? What we really need, and this is my brain dropping next, is we need a healthcare system. Not a sick care system, not one that focuses solely on rescue medicine, as the metaphor that I said at the beginning implies, and not one that solely benefits from illness financially, as we got to see rather humorously portrayed at lunchtime, or one that lulls us into thinking that all will be well, just go for it. Eat what you want, live like you want, as we hear these incredible cellular, whether it's at the protein level, the genetic level, the RNA level, all that's going on. Don't worry, medicine's got your back. I think we need to be incredibly careful with that. So what I want to do now is just sort of turn real quickly and look upstream, or as we say, go out on a limb. And it is going out on a limb. I say that because we in medicine don't necessarily think in systems, as I think it was just actually said in the last lecture. And when we look at what's upstream, there's actually an exciting resurgence of interest in both community and public health. And I decided, I was trying to think as I wrote that, is it a resurgence, is it a renaissance, or is it really just recognition that there's important work that's been happening in public and community health that are going to be so critical to actually transforming and leveraging all the amazing technologies and science that we're learning downstream? It's really hard to say, but the one thing I do know is that it really isn't a movement. We're getting there, but it's just the beginnings of one. Part of that is because change is slow, and part of that is because it's been the interesting thing to watch, sort of the technology explosion in this country that in healthcare that we've had. We call it in the hospital business, they'll get a 64, who knows how many slice CT scanners we're up to now, and then the one across the street has to get one, and then back and forth and back and forth. It is a crazy business model. That doesn't necessarily pay for itself in ways that are logical. But at the same time I say that, I actually do believe that there is a way for us to get upstream, figure out how to create systemness, and do it in a way that respects the fact that there's a business model that could work there. It's just going to take somebody who can think of this through ingenious ways. And the way that I put it, how do we create a business model for some innovative, socially conscious capitalism? Because that's what we're going to need. And I'm crazy enough to believe that we can, and not only that, I'm crazy enough to believe that addressing this could be the key to a number of ills that are outside of healthcare. And as a hint, think about the opportunities upstream, none of which I've laid out yet, but I will, that could actually improve our education system, can improve economic self-sufficiency and opportunity for folks as we start thinking about what's upstream and needs work. Well, one of the first things and the most important things, and I don't know if you've ever heard this phrase, but it turns out, in contrast perhaps to some of what you've heard this morning and may hear tomorrow, that your zip code is way more important in determining your health outcomes than your genetic codes. It's one of the not so dirty little secrets that we choose to turn our faces away from. And I don't say that in a sense of guilt. I didn't come from privilege, but I'd be lying if I didn't say, I guess they tell me I'm wealthy. Until I look at my checkbook, they tell me I'm wealthy. And so I don't say it in this way to make anybody feel guilty or bad, but the reality is that your zip code is more important than your genetic code. And it gets to something that really is the big lens when we look upstream called the social determinants of health. And that is those conditions into which we're born and we live and we die that way more impact our health and certainly impact what you look like when you come to the doors of the healthcare system, which is the work that we need to set about. So as we think about it, and I've got the areas listed up here, one of the things, and I don't know if you've heard this work from McGinnis, this was a Health Affairs article from 2002, that went on to show the impact of various things in our that we are either in our environment or who are us around our overall health. And the interesting thing is that $2.9 trillion that we're spending on healthcare impacts your overall health 10%. It's these other things which we're spending precious little money in as we think about our social circumstances, our environment, and in behavior. That really are going to be the big gears. If we can get those gears moving, that we're going to begin to see the real change, the transformative change that's going to enable us to really use those tools in healthcare in a responsible way to improve both the efficiency and the effectiveness of the system. Here's another way to think about it in terms of what those are and getting a little bit deeper. There's the social and the community context, and it's why I started this off with, I just love the questions that came out, because it really did, they sort of lifted up that the part out of all of it, in addition to the science that you all picked up on, that really is truly revolutionary and transformative, is you all have included patients in the health care. They're there helping you make those care decisions and probably even driving research. And that's one of the things that the Affordable Care Act did lift up with the creation of the Patient-Centered Outcomes Research Institute, which says that patients have to be involved in the development and design of studies, what's going to be studied, and how those results are going to be disseminated. So we're moving slow but sure. So this notion of understanding social and community context, this one's a huge one. And actually, not only is education a huge one because of what it enables all of us to do in terms of our lives, but I don't know if you know this, but kids who can't read by 3rd grade have an increased likelihood of A, not graduating from high school, but also going to prison. And in fact, there are places in this country where some of the projections around the number of prison beds we need is based on what the 3rd grade reading levels are. I mean, that is tragic. And here we are playing with our genomics and our proteomics, which are fabulous, and we can't solve this one. 3rd grade, read on grade level by 3rd grade. Neighborhood and environment, you know this so well. Commerce City in this community, for those of you who are in the Front Range, has much higher asthma rates than other parts. We can track asthma rates based on what the environment looks like. And in that particular case, the connection, I believe, is it's the pollution. It's the air and the refineries that are up, the oil refineries, and the impacts on kids' health. But then there are other more subtle environmental issues that can be playing out as well. And certainly health care and access to health care is also a social determinant. But it's a relatively late one. So here's what I want to sort of end my remarks thinking about, is really this notion of imagining a system. Imagining a system wherein we dream big. And first of all, the critical part of that systemness means that we've got to expand the tent. We have to expand the tent beyond what happens in our walls. Patients spend 20 minutes on average with us in our offices, and if they're lucky, they're there once a year. Health doesn't happen in our offices. That's a dirty little secret. We don't make people particularly healthy, and health does not happen in our offices. Health happens out there where you, as we say, live, learn, work, play, and pray. That's where health happens. So we've got to draw the box more broadly. We've got to recognize that health isn't the absence of disease, and more importantly, that health is not necessarily health care. We need to recognize that there's only so much that therefore can be accomplished within our walls, and we need to consider these social determinants and the impacts on health and the ability to engage actively in health care. We need to consider them through an interesting dual lens, and I believe this, I really do, because I think we're smart enough here in this country to figure out how do we take this market-based capitalist society we have and figure this darn thing out. So the dual lens is a workable business model and a socially and ethically values-based model. We can do that. And we have to hold each other accountable by understanding the interplay between independence, or, you know, it's been a ton of finger pointing in our country in the last many years, especially on the political scene. And we play off this sort of personal responsibility against our interdependence, that is our community or our social responsibility to come together and build strong, cohesive communities. More importantly, I wonder how would we go about creating such a system and in turn transform both the healthcare system within and without. And there are some interesting things, and if you have a moment to go out and look at the TED Talk, I took each of the places along thinking about this imaginary river, and I talked about work that's going on in each one of those settings that really do show that if we are willing to expand the tent and really think that if fixing healthcare won't fix healthcare, perhaps there's some answers to be found in building community. How are communities being built, and how are we really interpreting that differently? So the interesting thing is I think about what we're doing down in the healthcare system to create a sense of community is we're expanding the definition of teams. You know, when I trained long ago, you know, the doctor was king. We saw a little bit on the stage at lunchtime today, or queen, I guess queen too. And we really did. We were trained in that medical model, and unfortunately, I think it's still out there that we have to do it all. And we can't be everything, everywhere. It just doesn't work that way. So we have to begin to think about how do we build teams, how do we work off of protocols and processes, and figure out how to create cultures where we flatten hierarchies so that we can build safe, equitable healthcare systems. At the same time, how do we begin to think about school environments as places for not just this notion of learning, but what are all the antecedents to learning? Well, one of which is kids need to come to school healthy and fed, and come from environments where they're not living in toxic stress, and they're therefore ready to learn. When we think about prevention and some of the simple ways and some of the simple prevention measures, which in this country we're spending about 2%, we're investing in prevention of disease as opposed to the 2.9 trillion, 2% of that 2.9 trillion that's really going to prevention. What could we do if we began to think about that differently? And I tell a story in the TED Talk of a village in Africa. Gosh, it's been too many years since I did the talk. Nigeria, Uganda, and Tanzania, where the adherence with treatment for HIV is greater than we're getting in this country, the treatment adherence. And it's all because they've really built this notion of community. And they've laid out the expectation that people will take their medicine because they've been able to tie it very, very directly to take your medicines, you won't die, and you can take care of your family. Understanding the values that were important in those communities. So we've really got to think through a system wherein it's that way. I know many of you probably do know Don Berwick, from the Institute for Healthcare Improvement. And there's stuff that we don't consider in the clinical encounter that is important to consider. And there's stuff that we're going to need to consider, factors we're going to need to consider as we try to now back downstream in the healthcare system, build a system that, as it said, is steep per the Institute of Medicine, that is safe, timely, effective, equitable, and patient-centered. And what Don Berwick has set out and said that we've got to do as in this post-ACA world, because the ACA is not going to solve all our problems, is a few things. One, design and nurture systems that expect and embrace change in the continual pursuit of improvement. We've got lots of work, I can tell you, to do there. Change the balance of power so that health and well-being can be co-produced in partnership with patients, families, and communities. Cultivate and mobilize the pride and joy of the healthcare workforce, which has been beaten out of us in the last many years. make it easy, continually reduce waste and all non-value-added requirements and activities for patients, families, and clinicians. Move knowledge, not people, exploit all helpful capacities of the modern digital age, and continually substitute better alternatives for visits and institutional stays. Meeting people where they are is going to be one of the big bets from a technology leveraging space that we could do some really good work. We have to cooperate and collaborate above all. Eliminate silos and tear down self-protective institutional professional boundaries that impede flow. Assume abundance. And the interesting thing about this, I had a chance just to do a talk yesterday for women in government, the state legislators from this western part of the country. And it's interesting, when we go into communities that are, we'll say, in need, we go in with a deficit mindset, and we don't assume abundance, and we certainly don't assume an asset-based mindset. I can tell you, there's no way that I could live on the budgets and balance these budgets that many families in this country are balancing every day, because then I wouldn't be able to get really cool shoes like I have on today. So I mean, really, people are struggling out there, and they manage to do it. That's asset-based thinking. And if we go into communities with that and collaborate and cooperate with communities, I think we can get pretty darn far. So this notion of assuming abundance. And then return the money from healthcare savings to other public and private purposes. Aim for total healthcare expenditures at or below 15% of our gross domestic product. So, one of the things that we do talk about in terms of the clinical encounter is we call our patients non-compliant or non-adherent, and we don't think about the things that are getting in the way of the ability of our patients to actually care for themselves. And it's all that upstream stuff. Nobody wants to not take their meds. They really don't. No one wants their kids to become ill or have readmissions to hospitals, and we certainly don't want our aging loved ones that way either. But the contributing factors of financial, of food insecurity, of transportation, of these high deductibles that unfortunately are plaguing our health coverage system now, really require that patients have to make priority trade-offs. We need to think about the impacts of chronic and toxic stress, because it's real, and it's real important. And it's not only important in terms of how people are feeling from a behavioral perspective, but we're understanding more and more about the cellular effects, the physiologic effects of toxic stress, violence, and other things. And then there's this whole notion of the lack of social cohesion. If you haven't, you should take a look at Robert Putnam's book. He's got a new one out, actually, by the way, about education, but he wrote a book back in 2000 called Bowling Alone. And it helps us to sort of think about how have we pulled the fabric of our society apart. And then those things do have impact on how people look when they come to our door. For me, it's difficult not to get emotional about this, and I'm passionate about it. And I refuse to get verklempt and get teary-eyed, so pull it together, Jandel. And yet it is. It's very difficult not to get emotional about this. I took care of patients for 25 years. Oh, look at me. Thank you, Larry. I'm going to look at you. And there were so many times in the privilege of taking care of all sorts of folks from all sorts of socioeconomic status or strata that I thought, what this person needs is not to be found at the end of a scalpel or at the bottom of a pill bottle. We're dealing with people with broken spirits and broken hearts, and we have to have the ability to create those conversations and create the space and the places within a much bigger tent as we think about redesigning our healthcare system in order to get this done. As somebody told me years ago when we were doing some work around some of our diversity and inclusiveness work at Kaiser Permanente, and we were struggling over some process issues internally, Dr. Melanie Tervalon, a pediatrician who was running the programs from our corporate level at that time, looked at us and said, "People are dying." And those are words that just sort of ring in my head every day as I think about the work that we've got to do to transform our system. Because meanwhile, back at the farm, people are dying. And more importantly, our economy is suffering because of our failure to think in systems and to seek systemic, coherent solutions to a number of seemingly intractable problems, of which health is but one, and it is an important one. So to the end, what I'd say is, I do think we're on a fertile verge. If we're willing to sort of think about these sort of seemingly disparate brain droppings that I hopefully I've pulled together into some sort of a coherent story. And really think about how do we now begin to pull in those upstream factors and use them to help us solve the issues that we have down in our healthcare system while continuing to work on system reform. What do I think? I'm infused at the same time that I'm feeling emotional and sometimes very overwhelmed by this thing, but think that we are really on a fertile verge. That the whole area upstream is ripe for exploration. It's ripe for the creation of some really cool systems that, as I say here, are powered or fueled as appropriate by technology. And I think if somebody, could be any one of us in this room, but it'll be some creative souls who are going to figure this out. And then this is that sort of statement you always want to stay at the end, which is sort of the one that I hope makes us all stop. Someone better figure it out, or God help us. Thank you.
Thank you, Jandel. That was wonderful. She'll take questions.
So I wanted to put together two parts of your talk that I found stimulating. One was this: the zip code is more important than the genetic code in terms of healthcare outcomes in this country. And then your graph that the UK is doing better overall in terms of getting bang for buck on healthcare expenditures. Within the UK, is there also a steep gradient between rural, disadvantaged areas versus cities, or have they flattened that out?
You know, I don't know the total answer to the question, but I'll tell you what they have. And if there's a distinction between what we're seeing in across the globe compared to the United States, is there's been a much bigger focus on community and public health. That is one of the big distinctions. Now, the interesting thing that we're seeing happen as they get McDonald's and change their diet, and we move more into the cities where there's less opportunity for walkability and bikeability, they're seeing the same rises in chronic disease, the same rises in obesity, and some
So they'll catch down to us at some point?
Yeah, it's a race to the bottom, Tom. Thank you. Yeah. We should give.
It's about 4 or 5 years. So about 50% of it is socioeconomic status, because in all countries, people that are worse off smoke more, are more obese, yada, 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 for a variety of reasons. And there's some measures to social autonomy. So we're about twice as bad.
I have one, and I have a microphone, so I'm stealing. It's the first one today, so I'd like some credit for that. So I've heard you talk now 3 times in less than a half a year, and I think each time it's more inspiring, so that's the good part of my question. But there's a loaded part coming. I can imagine that at Kaiser Permanente, which many of you don't know, it covers roughly 3% or 2.5% of the people in the United States, something like that. So it's a big system, and it's doctor-owned or whatever. It's a not-for-profit.
It's a marriage.
It's a marriage. I get that. So I imagine that in the hierarchy of the people who are in the leadership positions at Kaiser Permanente, on the administrative assistant's phones, on a sticky pad, it says, "If Jandel calls, I'm out." Okay? And I think that's a really important question that I'd like to now ask. I actually have a real question, that's not an insult.
Oh, no, I was going to.
Yeah.
2 in the morning, I'll figure out what it meant.
Yeah,
But
okay.
yes,
So
carry on.
here's the question. When I think of the experiments that you would like to see done, I cannot think of anyone in the United States better situated than Kaiser Permanente to solve this problem. For example, if it's true that kids go to school and they don't learn to read, then Kaiser Permanente could put into its programs reading programs. They could make food for poor families. Kaiser Permanente could say, "We're tired of you, Congress. We're tired of you, and you're our members, and we're going to fix what's wrong, And we're going to be the experiment that shows the country
That we
what to
can
do.
do it.
Yes.
So, this could have been a 7-day talk, but the interesting thing is we're going there, and we're now beginning the work of clinic community integration. You know, and so there's 2 programs that I'll tell you that we're leveraging for our members. One is Nurse Family Partnership, and if you don't know about NFP, you should know about NFP. Nurse Family Partnership is in 48 states. It's a nurse-administered program that starts prenatally, and they try to start at no later than 28 weeks estimated gestational age, and it goes to 2 years in their home visits. They have 30-plus years of evidence that show a few things. Decreased all-cause mortality in the kids, decreased all-cause mortality in the moms, and better reading by 3rd grade, higher high school graduation rates. We are now screening, and we refer our low-income moms to that program, and are beginning to get the data that are showing that we have decreased risk of low birth weight kids being born compared to the women who don't. And the interesting thing about it is you would think, oh, that must be the Medicaid women. 50% of our referrals in this program have been Medicaid. The other are commercially insured, because the only difference between, we sort of act like the unwashed just came into healthcare. That's not the case. In fact, in our population, it's estimated about 40% of that 10 million of our members are low income. They just happen to be blessed and have a job where the employer offers insurance. They go home to the same stressors as everybody else. The other program is Hunger Free. We are starting to screen for food insecurity because there is a direct and a growing body of literature that shows that food insecurity is associated with obesity. Go figure that out. You're eating that stuff I showed you on the slide. It's not that hard to figure out. So food, and it's also associated with poor diabetic control and is implicated in poor control and outcomes of a number of other clinical conditions. So people come into the offices, their hemoglobin A1Cs are out of control. In fact, the pediatrician, Dr. Sandy Stenmark, who's leading this work, I bet you know Sandy, she's my girl. Sandy has shown that pediatricians who are treating kids with failure to thrive never ask about food intake and what's happening in the home. So we started screening our patients for food insecurity. We're actually one of the funders of Hunger Free Colorado, which was stood up as a nonprofit in 2008. And we've been referring people. We did a pilot back in 2012 and showed in 2 of our clinics in our commercially insured population, 12% of people were screening positive for food insecurity. And we're referring them. Next step, and this is where technology can fuel this, which is really cool. The next step with this work, when we think about clinic community integration, is it's not about grant funding, which we do out of our community benefit work. It's really about now contractual business arrangements with Nurse Family Partnership and Hunger Free and all the other social wraparound services. There has to be, as part of that contractual agreement, some standards, we expect some outcomes results that we're going to be paying for. And the third is interoperability. This is an expanded definition of the care team, and if they're part of the care team, they need access to our electronic health records. And so those are the 3 components of clinic community integration. We're moving there. I'll tell you, it's not as easy as you'd think, because as wonderful as we think we are, we've now just added more work to a physician's plate. We have to figure out how to then integrate this into the system, and I could talk forever. You want me to shut up? I bet.
I think with that, we should thank Jandel. That was fantastic.